Hello, I'm Faith Rogers, host of today's program, COVID-19 Keeping Up with a Moving Target. This is the May 7th episode of DKB Med Radio's Coronavirus Educational Series. Thank you for joining us. This activity is jointly provided by the Postgraduate Institute for Medicine, DKB Med, and the Institute for Johns Hopkins Nursing. Today's program is accredited for ANCC and AAPA credit, as well as AMA PRA Category 1 credits. Please visit our website for complete CE information. If you're tuning into our webcast, please click the red Claim Credit button in the webinar console to attest for credit. Otherwise, please visit covid19.dkbmed.com. Today's learning objective is to discuss COVID-19 vaccine considerations for patients with multiple sclerosis. This educational activity is supported by independent medical educational grants from Gilead Sciences Incorporated, Regeneron Pharmaceuticals Incorporated, and Eli Lilly and Company, as well as in-kind support by DKB Med LLC. All activity content and materials have been developed solely by the activity directors, planning committee members, and faculty presenters. With us today, we have Dr. Paul Auwaerter, Clinical Director of the Division of Infectious Diseases at Johns Hopkins School of Medicine. He will be interviewing Dr. Kornberg, Assistant Professor at the Department of Neurology at Johns Hopkins School of Medicine, as they discuss multiple sclerosis and COVID-19. Dr. Kornberg is also the Program Director for eMultiple Sclerosis Review's COVID-19 Special Edition. In this newsletter podcast combination, Dr. Kornberg analyzes what we currently know about MS and COVID-19. Then, with guest experts reporting from the field, he discusses how the latest clinical data impacts practice. COVID-19 and MS, what we currently know. Read the newsletter or listen to the podcast available now at emsreview.org and linked in the episode resources. Dr. Kornberg, Dr. Auwaerter, thank you so much for your time today.
Thank you, Faith, and really want to thank Michael for joining us today on a topic where ever since December has been one of the most frequent questions amongst my patients or colleagues that are trying to get patients immunized, and that is, are there special patient populations that have to worry about being immunized, activating their disease? So, Michael, I'm sure this has been an issue. Patients that have had lupus, patients who have rheumatoid arthritis, inflammatory bowel disease, but especially when the brain's involved, I take it no one wants their disease to flare at all. Just straight out of the box, I mean, does any of our vaccines, are they going to make MS worse?
So it's a great question, important question for patients, but also, for doctors as well. I mean, it's been kind of at least a theoretical concern, since the 70s, vaccines and MS. The short answer is no. That's never been borne out in studies, that vaccinations, generally, in a population have not been found to trigger MS relapses. There have been, specifically with the COVID-19 vaccines, there have not been dedicated studies in MS patients. There's been one that I know of, a study of about 400 patients in Israel with MS who had been vaccinated with the Pfizer vaccine that found no increased risk of relapse and no other complications. But most of our knowledge comes from extrapolating, what we know based on other vaccines. And probably the best evidence we have comes from the yearly influenza vaccine, which, very clearly has been shown to lead to no increased risk of relapse or other complications in MS patients. But a number of other vaccines have been studied, and there's never been a signal in terms of triggering MS relapse, either a first relapse, for people before diagnosis or subsequent relapses. And interestingly enough, there have been a number of vaccinations that have been shown to be associated with a decreased risk of having an MS relapse after vaccination. And so, I think it will always be kind of a theoretical concern, but the reassuring thing is that whenever it's been studied, that risk has never been borne out.
Yeah, I tend to also cite the influenza studies because that's really where our most extensive experience has been and is the most frequent vaccine that's used. But on the other hand, I think it's hard to convince patients, especially when there's something new. And it's a fraught decision personally, I think, for so many of them. But I try to put it in the context of the actual infection. And if you were to develop severe infection, how do you balance the impact on your disease versus the theoretical one of COVID-19, and especially now where there's some helpful information, especially from real world studies like the one in Israel.
Yes, no, I agree. And I also, I also understand that it is a fraught decision for patients. And, so I certainly, try hard, I mean, never to minimize their concerns and be very clear about the fact that, our data when it comes to, our knowledge when it comes specifically to these vaccines, which are, new technology and, in a way, that we don't have definitive evidence. But I frame it much the same way that you just stated, that in the scheme of things, when you're talking about risks from getting COVID-19, which we know very well, versus theoretical risks that I think are very low given our experience with other vaccines, it becomes an easier decision. But I certainly understand why many of my patients agonize a bit over the decision, because even oftentimes their primary doctors, will raise concerns about, whether they should be getting vaccines given their, their autoimmune condition. And so, when that's the case, you certainly understand, where people are coming from.
Yeah, and I think it's a general, I mean, because it makes some biological plausibility, right? Oh, the immune system, you're activating it,
Yes.
especially, with the COVID-19 vaccines, which probably are just the lipids jazzing up our innate immune system briefly. So, it's certainly understandable. Uh, on the other hand, I wanted to ask a little bit about your insights or any concerns you may have about your patients and the kind of medicines that are being used to treat their MS. I mean, of course, there's steroids, which might just be briefly used, but your longer term medicines, I've always found in MS tend to be a little different than the panel of drugs that are being used for most other auto-inflammatory diseases, probably because I've always learned that, or I don't know if it's still true, that the brain might skew more towards Th2 responses, and you don't want a lot of swelling in the brain and these sorts of things. So maybe your drugs are a little different. What's your sense, just even from other vaccines, if of course we don't probably know for COVID-19, do they impact vaccine responses? Should your patients be a little more concerned about whether they need boosters earlier on? Do they still need to be super cautious, when community rates are still pretty high for COVID-19?
Yeah, so very important question. And you're right, that the cohort of drugs that we use, there's starting to be some more overlap, with rheumatologic conditions, but there are a lot of distinctions, I think, for a variety of reasons. And MS has a wide spectrum of severity, and so people can be on a wide spectrum of disease modifying drugs. And we do have quite a bit of good evidence in terms of immune responses to other vaccines that we feel like we have a pretty good handle on, who might have a diminished response to the COVID-19 vaccine and who might not. And broadly speaking, it's kind of a distinction between what we call immunomodulatory drugs and immunosuppressive drugs. But in MS, there's a number of drugs that we don't think at least are likely to have any impact on the vaccine response. And so those include the interferons, which were the first MS medications, and we have very good data that interferons do not impact vaccine responses from studies of a number of different vaccines. And then there's things like glatiramer acetate, which also is just very mild immunomodulatory drug. and kind of a whole class of drugs on that end of the spectrum that, we have good evidence that, they either don't have any impact on vaccine responses, or have a mild impact that we don't think would be functionally relevant. And it depends on mechanism of action. So we do have some more targeted drugs like natalizumab that basically just block trafficking of lymphocytes into the brain. And again, based on mechanism of action and the evidence that we have, we don't expect that there's going to be a major impact there. And so for those patients, I really just offer reassurance that I don't expect their response to the vaccine to be any different than anyone else's. There are medications that we do have to worry about response. So two of the biggest ones are the S1P receptor modulators that basically work by trapping lymphocytes in the peripheral lymph nodes. And so they're not kind of out surveilling the rest of the body, and you don't have as much of a local response to a vaccine. And there's good evidence that from other vaccinations that they do diminish your response. And the other big one is the anti-CD20 therapies, which are now very commonly used. So, rituximab, kind of the old school version, but now we have ocrelizumab and ofatumumab. And those drugs have also been shown to blunt the vaccine response. And so, for those patients, I tell them it's definitely worth getting vaccinated. Partial immunity is better than no immunity. None of the prior studies have really looked well at cell-mediated immunity, which obviously is going to be very important for your protection against COVID-19. So they should definitely get vaccinated, but there's kind of two issues. So to your point, I do tell them that we don't know how much protection you're going to have from this vaccine relative to someone else. And so, you can't, don't feel quite as, scot-free as, maybe your other family members, or friends do. And so, I just caution them to still take basic precautions as long as the rates, of COVID in the community are high, as long as other members of their household are not yet vaccinated. And so I just, urge them to stay vigilant, but have a little peace of mind that they likely are not as much at risk as they were before. And then the other issue comes with timing of medications. So, for patients that we're going to start on these medicines, like the anti-CD20s, the question comes, do we delay it so that you can get vaccinated first, and then start on the therapy, which we obviously have to weigh against the risk of their MS worsening. And then for patients who are already being treated with therapy, is there any utility to timing the vaccines in response to when they're going to get doses of their medications? And in that setting, the data is weak, but based on some extrapolation, we try if we can to vaccinate against COVID-19 about 12 weeks after they've received a dose of anti-CD20 therapy, and at least 4 weeks before they're due for their next dose. You ask me, do I think that really makes a difference? I don't really know, but that's the general guidance. And so there are issues surrounding these medications and vaccination, but it depends to a great extent on what medication they're taking. And then the last thing I'll say is that we also have to think about the risk of these medications when it comes to their course of COVID. So the anti-CD20 therapies are really the one therapy that has been shown to have some increased risk of a severe course of COVID. And so you have to weigh, getting partial immunity as quick as possible, with, the possibility of, of trying to optimize their immune response.
Yeah, so Michael, those are great comments. And certainly I think as infectious disease practitioners, we've been urging, especially people on the B-cell depleting therapies, to if they have any symptoms of COVID, get diagnosed as soon as possible. And this is where some of the monoclonal antibody infusions, I think, are especially important to really try to decrease risk for progression to severe COVID. And then we'll see, but there'll probably be prevention strategies with monoclonal antibodies, with subcutaneous injections of some of these cocktails or the monoclonals coming out, which may be quite unique to populations such as some of your MS patients, especially if there's very high community rates that can afford them some protection beyond the mask.
Yeah, well, I will look forward to that. I'm sure a number of my patients will also.
Yeah, no, I think it's, obviously the best way to help your patients are as many people in the United States to become immunized. But lacking that, and I'm not overly hopeful we're going to get 90% of the US population
Yeah,
immunized.
yeah.
These monoclonal antibodies may be an important part of the repertoire for either treatment or protection moving ahead. So
Yeah. The other point you raised, which we don't really have at least a concerted answer for, is the question of booster booster vaccine doses. And if those do become available, I anticipate my approach being that all of my patients on anti-CD20s should be kind of first in line. But the question has come up among our MS group, is what's the utility of testing for spike protein antibodies, in terms of kind of triaging who should get booster doses or not. And to me, I haven't really been willing to extrapolate so much to use that as an outcome measure to I guess assess a patient's risk after vaccination. But I don't know if that's something that has been discussed in your circles also.
Well, of course, and I think we don't really know the correlates of protection, especially with spike antibody levels, and so that's a difficult one to answer. I think by and large, there probably won't be an antibody assessment recommendation. I think it will still be a patient population and time assessment, just to get out of the rigmarole of having to get a blood test to interpret and then decide if you need a booster, is just my feeling. Although I think there'll be a gray zone of some weeks or even months where we don't know any of these answers, and a third dose is recommended. But it will become soonest, though, in the patients that you just mentioned, those people that we don't think are going to respond well. Thank you for those terrific thoughts about special patient populations in MS, drugs, and immunizations. I hope that the advice to have people still get immunized carries forward and helps all of our patients and our communities by offering as much protection as possible. So thank you so much for joining the program today.
Thank you for having me. It was really my pleasure, and thanks for sharing your insights as well.
Dr. Kornberg, Dr. Auwaerter, thank you again for your time. For more information on COVID-19 and MS, you can read the newsletter or listen to the podcast of Dr. Kornberg's EMS Review COVID-19 Special Edition by clicking on the link in the episode resources or going to emsreview.org. If you're tuning into our webcast, please click the red Claim Credit button in the webinar console to attest for credit. Otherwise, please visit covid19.dkbmed.com. Any questions or issues, feel free to email us at the address listed. To submit questions, please send them to qa@dkbmed.com. That's Q as in question, A as in answer, @dkbmed.com. Again, thanks for joining us, and thank you for your dedication to your patients with COVID-19.